Awesome. Welcome everybody to the February 2024 United Spinal Association Northeast Ohio Chapter monthly meeting. We have Dr. Rob Hoey with us tonight to share some updates on the genital nerve stimulation bowel study that he is the principal investigator of, that's being held at Metro Health. And kind of ask us for our thoughts and feedback in the process. So the research is important to hear feedback from all of us. So be as open as you are comfortable sharing. And please share if you have something to say. So Dr. Hoey, thank you for joining us, and I will turn the table over to you.
Well, thanks for having me. Let me just share my screen real quick. And I don't mind if you want to just ask questions as we go. Hang on. This is not Word. Hang on a second. So I did want to talk to you about the research that we've been doing. So this is something that I actually came almost to the day last year to talk to you guys about. Since it's been a little while, I wanted to go through a little bit of the methods and kind of explain what we're doing. And again, feedback at any point is great. And so basic outline, just going over the study a little bit, and then how we've been doing on recruitment so far, and then results update and a chance for feedback. So I'm hoping not to take a super long time. It's a bit sciencey, so if you have questions or you need me to stop or explain something, please feel free. I just wanted to talk about the team a little bit. So I'm actually working with Kim Anderson, who I think you guys know pretty well, and Dennis Bourbeau and Christy Hensel over at the VA. We have two lived experience consultants, Amy Binko and Ed Stitz, and they've been very helpful in the creation of materials and kind of bouncing ideas off of when we were designing the study to make sure that it was something that would fit with the goals as well as the comfort level of the community. Our clinical team, James Wilson, Lainey Cordy, and Aubrey Fairfull have been great in the execution of this study, and our research coordinator, Ashley Calloway, is fantastic. So this is funded by the DoD, and it's 4 years, so we're just past the first year. So we've done like the first quarter report since the annual. So the people that we're looking to include in this study, it has to be traumatic STIs. So that's falls, assault, car accidents, things of that nature. We didn't want to get into things like mechanisms of disease or things like that that could lead to spinal cord injury, because we wanted to have, there's a lot of things in SCI that are very variable. So we wanted to try and limit that as much as possible so that we could get some significant results, if possible, at the end. At least 6 months post-injury, 18 years or older, and that kind of goes with the last one, being able to understand and provide informed consent. All neurological severities, so A through D of injury. We're really looking to see how bowel function, how complications from SCI in bowel function are spread across that severity spectrum. Also, because of the way that the nervous system is organized, we wanted to have T12 neurological injury or higher. Any lower than that, and you start to get into the spinal segments that actually control these organs. And so if there's damage to those systems, you wouldn't be able to respond to the stimulation. And so we wouldn't really be able to determine anything. And then you have to actually respond to the stimulation to be included. So it's actually fairly simple. This is an acute presentation of stimulation. And so after recruitment, you come in for a screening, and this takes about 2.5 hours. There are some questionnaires as well as some, there's a spinal cord exam. So this is the INSCI, which I'm sure you guys are familiar with. Bowel and genital reflexes exam. So that's actually part of the INSCI, but we also go a little bit further and do that genital nerve stimulation. So we actually will test whether the stimulation causes a response. And typically, because we're looking at the bowel system, we're looking for the anus to contract slightly. I guess, spoiler alert, I will be talking about bowel function and the anus and things like that. I don't know how comfortable you guys are with that. If the screening looks good and the lesion level is above T12 and everything else, you responded to the stimulation, then we can move on to the anal rectal manometry part. Now, this is actually a fairly gold standard test for bowel function across able-bodied as well as injured people. And so this is something that tests the anus and rectal reflexes and how the organs actually function. And so what we're trying to do, so you can put them in one day. It's a long day. It goes from about 8:30 to about 2 in the afternoon. It's fairly long, but we are able to do it all in one day. And really, we want to understand how the stimulation affects that reflex activity. And also, is there anything about the individuals that come in that would tell us whether or not they would respond to the stimulation positively or not? It's kind of a big ask. So this is the first kind of large pilot study looking at this technique. The benefits of it are that it's non-invasive, so you don't have to have surgery. There's nothing implanted. This is simply electrodes placed onto the skin, and we can actually affect. There's been a lot of studies showing that it leads to larger capacities and reduction in reflex activity in the bladder system. So if you're having a lot of urge incontinence at low volume after injury, this stimulation can be used to kind of calm the bladder down and allow more filling and reduce incontinence episodes in the bladder. So we were hoping that because the systems are very similar and they're all controlled by a very similar part in the spinal cord, so it's all kind of intermingled down there in the pelvic region, we thought that maybe the same effect would apply to the bowel system as well. So that's what we were hoping for, and that's what we proposed to look at. So this is how we're doing it. This looks like a lot, but essentially this is one run of this London classification. Now, this is the way that we actually test what the system is doing. So we ask the person, and again, with spinal cord injury, this may be something that can be done voluntarily or not. We really just ask for best effort, right? So what you think your body needs to do the task. So the first is a rest right here. So you just get some baseline activity, and then we ask you to squeeze as if you're trying to hold in a bowel movement. Again, voluntary anal contraction isn't always present after injury. And so again, it's just best effort. We'll do that 3 times, and then with breaks in between. And then there'll be a long squeeze, which is just same as above, but up to 30 seconds. And then a minute rest, and then we'll do 2 coughs. So this is to check the reflexes that promote continence due to kind of sharp increases in intra-abdominal pressure. So if you cough or you sneeze, there's a reflex that actually closes the anus so that you don't have an incontinence episode due to this activity. And so we wanted to see the integrity of that. And so 30 seconds, there's 2 of those, and then 30 seconds in between. And then we'll ask the person to push as if they're trying to have a bowel movement. So this is bear down, whatever it is that you need to do to kind of help yourself have a bowel movement. We do that 3 times with rest in between. And then at the end, we do some reflex testing. So the rare is an inhibitory reflex. Essentially, the anus stays closed most of the time. That's its default position. And so what happens when stool moves into the rectum is that it will stimulate a reflex that causes that to loosen so that you can have a bowel movement. This is important for defecation, and it's kind of part of the process that this inhibitory reflex is actually a non-voluntary sphincter that loosens. So typically, if you don't have an SCI and you do have voluntary control, when that starts to happen, you can close the external sphincter voluntarily to give yourself time to go to the bathroom. After injury, that isn't present in every individual. So this is really just seeing if that reflex is intact and how sensitive it is, because there can be changes in the sensitivity after injury. The sensory testing, so the way that we detect the rectal pressure is with a balloon. And so during this part, we will infuse the balloon with saline to inflate it and distend that rectum. And we're just asking the person, when is the first time you feel something? So first sensation. When do you feel like you should move to the toilet? You have an urge to go to the bathroom. And then when it's called max tolerance, and it's basically the analogy we use when I have a person with us is the first time you feel something, when you feel like you really have to go to the bathroom, and then I'm going to poop on you. So those are kind of the 3 different levels that we're looking for. And so this sensation actually isn't present in every person, but depending on the injury and the severity, it may be or may not be. So we're really just looking at how sensitive this is. And sometimes these tell me when you feel something is, well, I know when my bowel's full, I get a weird twitch in my shoulder. So there can be a lot of referred sensation after SCI that can clue people in that they may need to empty their bowels or empty their bladder. And so really that's kind of what we're looking for. We're trying to make it as accessible as possible because we know that often after injury, these actions are not something that's voluntarily controlled. So we're just asking for best effort. And then the compliance curve is actually calculated from this sensory testing. So compliance is when material is going into the bladder, for instance, it will relax. And so it'll accommodate that increased volume without increasing pressure. So essentially what you want is a relatively flat curve. As the volume increases, the pressure doesn't really increase much. If you don't have good compliance, what's going to happen is you're going to have a more linear increase in the volume to pressure relationship. And I'll show you graphs of that in a little bit. And so this is something that's really looking at kind of that rectal tone and are you able to store? Because the main goal of both the bladder and the rectum is kind of like a storage. So there's storage and then there's empty functions to it. And after injury, the storage can be compromised in both the bladder and the bowel system, as well as the evacuation can be. And so really this is kind of just looking at what the system is doing. And so what we'll do is we'll do this 4 times. So we'll do it once at baseline. And so it takes about, I don't know, 12 to 15 minutes to do the whole thing. And then we'll give some time off. So you've got the first run is at baseline to see what is your body doing when you come in. And yeah, it's a weird situation and we try and make everybody comfortable. So it might not be exactly what's happening at home, but it's a pretty good baseline. And then what we'll do is we'll apply one of the 2 types of stimulation. So either a sham stimulation, which isn't supposed to do anything, or we call it a test stimulation. So one that is supposed to do something or did do something in bladder studies. Again, because this is the first pilot that's been done with this, we don't really know much. So you'll be tested with one stimulation, given a break, tested with the other stimulation, given a break, and then we'll do the baseline again. So all told, this takes between 2 and 3 hours to do all 4 of these tests, and then you're done. So the preliminary data that we used, I put this up as kind of, this is one of the traces that we would see. So as you're going through this, so this would be time along the bottom, and this is pressure. So at the top here is baseline activity without any stimulation. Okay, so this would be the person just came in, they were instrumented, given some time to acclimate, and then we started testing. So as you can see, there are these random spikes and dips in these different traces. Now, this is kind of that hyper reflexive response of that organ, right? So the sphincter, whenever the rectal pressure increases, the sphincter decreases pressure. That's defecation, essentially. So this person, as they were sitting there with the catheter in, and just during the rest period, they actually started to have some of these reflexive movements that would have led to an incontinence episode if there were material there to be evacuated. So you kind of have this situation where there's no voluntary ability to stop it or maybe even sense it, and yet the body is acting in a way that would lead to expulsion of material. And so this is kind of the baseline situation. And you'll see sometimes when the rectal pressure goes up, the sphincter pressure goes up. And other times it'll go up a little bit and then the sphincter will drop out. So really there's a lot of dysregulation in the system at baseline because the spinal cord is pretty good at doing things, but it doesn't do them super well. It really needs that descending coordination from the brain to really get it right. And so after it's been doing it wrong for a while, you get kind of this excessive reflex activity that just compromises function. So we've split these traces up, the rectal response and then the anal sphincter response. And when we applied GNS, you can see here, or general nerve stimulation, that trace kind of leveled out. So it actually started to get rid of some of these excessive reflexive perturbations in the signal. And we interpreted that as kind of a reduction in that hyper-reflexive stuff, almost like spasticity in limbs. You can also get that in the internal organs. So this is the rest period, and then I believe the squeezes were in here. These are the squeezes. So there was a little bit of increase in anal pressure, but not much past baseline when we asked that person to squeeze. These are the 2 coughs. So you can see a big increase typically, and this might just be from postural movement. And then here, these are the pushes. Excuse me. So typically when somebody tries to bear down to have a bowel movement, what you want to happen is you want to see the rectal pressure go up and you want to see the sphincter pressure go down, because then that opens the door and lets the material come out. But that actually doesn't happen in this individual. So in both the rectal and sphincter traces, when they're asked to push, they both go up. So this is very similar to DSD or detrusor sphincter dyssynergia in the bladder system. It's why you have to catheterize after SCI, because the sphincter locks down at the same time the bladder squeezes. That's essentially what's happening here. You get an increase in both of the signals when it's time to evacuate. And so there are a lot of parallels between this system and the bladder system. And so that's why we thought maybe this could be the mechanism that we could provide some relief for that incontinence. Because here, again, in the anal sphincter, you don't get these big decreases in pressure, kind of evens everything out. And so that seemed like a good idea. So we're getting rid of these rectal reflex contractions, and we're getting rid of the reflexive opening of the anus continence, right? That's what we're going for. Now, as everything in life that seems great on paper, the results that we're actually starting to get aren't as clear. So just a little bit about recruitment. This is very short. So there's a little bit of a lull here in our recruitment, as tends to happen over the winter time, and for whatever reason. But Ashley has been working very hard, and James Wilson reached out to some of the SCI patients that he has, and a lot of them have actually decided to participate. So we're hoping to increase this number quite a bit. Now it's in orange because it hasn't been done yet, and there are a lot of things that can happen between now and their experimental day. But if we can get all these done in the next couple of months, we're going to be much closer to on track. I would be much more confident. We just had another visit last Thursday that went very well, so we are up and running and conducting experiments. So we should boost our N by 9, hopefully by the end of this, for a total of 25. Now we do need to have another basically 25 in the next 8 months or so, and we're hoping to meet that goal. There's a little bit of wiggle room, but we're hoping to conduct quite a few of these studies, and by then we should hopefully have information to tell whether or not this is working. The benefit of this is that, again, it's surface stimulation and it's a $50 TENS unit. So this could be something that is very low bar to actually have this if it does help you. And so this could be something that could be offered if we were to show efficacy and safety, and the safety has already been shown in the bladder studies. But if we could show efficacy for fecal incontinence, this could be something that you could just order it online and start the next day once you get it, which would be great. So thus far, we're trying to get, we've kind of grouped them together into Asia A and B, and then C and D. I don't know if this is going to hold later, but this is kind of how we've separated those. We want to randomize. So we have 8 people that are either A or B, and 2 people that are C or D. And so we're really hoping to pump up the C and D group, because there are some really interesting things that I'm going to show you in the data that I think might make those severities respond differently to the stimulation than the other 2. Okay, so now to the meat and potatoes. Just a couple things to understand. So sphincter pressure in the anus is actually a combination of both smooth muscle tone, the internal sphincter, which is most of it, and then the skeletal muscle tone on the outside. And that's about 20%. Now, these types of muscle may be influenced by differently by the stimulation. And so this will kind of bear out in the results that I show you, but this is something to consider when I'm talking about these sphincter pressures. It's not just one or the other, they're both kind of working together. And so if you see an increase in these pressures, you don't know if it's from smooth muscle activity or the skeletal muscle activity. So it's a little bit in the interpretation there. But if we're just thinking about this, if you wanted to reduce incontinence, things that you would want to do, increase the resting pressure, right? That would prevent leakage. That would prevent kind of material just kind of passively moving out. You want to increase the squeeze pressure so that if somebody has the ability to detect when a bowel movement might happen, they would be able to try to stop that if possible, or promote this. Reduced push pressure. So if you can get that sphincter to relax when it should and tighten when it should, you can improve kind of bowel function. And so that push can lead to an outlet obstruction if it doesn't actually relax. And so that can lead with difficulty to evacuation and things like that that lead to a lot of extra time in the bowel program. And then increased cough pressure. So that's going to be that emergency reflex of, oh, I just sneezed. And that would help prevent having accidents due to things like that. So these are the things that we're looking for in the results that we're getting, because we think that those would promote continence. Now, in the rectum, we're not really sure what's going to happen. The things that we think of before we started, you want increased compliance, right? Because that's going to prevent that urgent continence at low volume. And we want to have reduced rectal spasticity. So these are kind of related to each other, right? We want to calm the organ down if it's excitable, and we want to make sure that it can relax when it's appropriate. You know, kind of like me every day, got to relax. So this is really what we're looking for in these data. And I'm going to show you some histograms, and I'll walk you through them. But essentially, these are the things we're looking for. And so you'll see at the top of each graph, it'll say resting pressure or squeeze pressure, things like that. And we do not have enough data for stats yet. I wish we did, but we don't. So I'll show you trends, and I'll say things like may mean or seems to. I'm not going to tell you it's actually doing anything yet because I can't say that. Once we get statistical significance, I can say that. But right now, I can't. All right. So these graphs are all set up the same. You've got the sphincter pressure on the left. Sorry about that. And you've got the stimulation condition. So baseline, sham, test, and re-baseline. One sec. Just getting over a cold, excuse me. All right. So the blue bars are the A and B group, and the green bars are C and D. This is only one person. And so that's what makes the interpretation really difficult, is that you've got 5 people in one group and 1 person in the other group. So if anything funky happens in that one person, now you've got something that looks like this, where in this resting pressure, so the long rest at the very beginning, what it looks like is from baseline, you have an increase when we give them the test stimulation. But it also looks like they have a decrease when they get the sham stimulation. But if you notice, the variability on here is huge. So again, with low data, low numbers of participants, we can't really say anything, but it looks like in the A and B group, when they get the test stimulation, there's an increase in that resting anal pressure, which is good. That's one of the things we're looking for. The same thing seems to happen in these short rests too. Doesn't look like it's as big of an effect, but it's similar. And again, this individual in the CD group, he just doesn't like to do what everybody else is doing. So when we give him the test, his sphincter pressure decreases in the short rest and the long rest, as you can see here. Now, in the cough pressure, which is another one that we were looking for, it does look like the stimulation is increasing in the AB group, that cough sphincter activity. So that's kind of promoting continence to these kind of sharp increases in intra-abdominal pressure. If you reach down quickly to grab something, you're going to have an increase in that pressure, and you want to make sure that you can maintain continence while you're doing that, or sneezing, because it's that time of year too. This push measure here, what we actually want is for this to decrease, so that while somebody is trying to have a bowel movement, they don't have the door closed. And it looks like here there isn't much of a difference in the AB group in this push pressure. But again, a huge difference in this individual in the C and D group. And then finally, that short squeeze. So this is something that's actually voluntarily controlled to a certain extent. They try to squeeze. And if you notice from the baseline resting pressure here around 45 in both of these rest conditions to the baseline here in squeeze, it's about 60. So there actually was a change from baseline in just from rest to trying to squeeze. There was an increase in pressure. So when voluntary anal contraction is tested in the INSCI, it's kind of around your finger or around the physician's finger, right? They see if they can feel it. This equipment seems much more sensitive. And so what we're actually starting to see is that things that on your INSCI sheet would be marked no response, we actually are seeing things change. And so that's kind of a benefit to this is that, you know, there are spared fibers typically after an injury, and they are able to do something. It's just usually not sufficient to do the whole thing. And so if we can promote those pathways through stimulation, we may be able to kind of rehabilitate some of these effects and maybe promote some voluntary contraction through strengthening those residual pathways. Is this stopped? Here we go. So overall, stimulation seems to increase anal sphincter pressure, but generally, right? So it looks like it's almost always in the test, and it's always, you know, about 10 to 15% more than baseline. But it doesn't, because it doesn't do anything here, it seems to also increase in push. It seems to be a general effect. We're just kind of stimulating the system to increase that sphincter pressure across the board, which isn't a bad thing if incontinence is an issue. But it isn't something that, okay, it'll do it while you're resting, but not when you have to push. So that's not really able for the stimulation to do. Now, the big question I had when I was looking at these is why do the green bars go down and the blue ones go up? So I know they have different severities of injury, but that didn't make any sense to me. And so I'll get to that in a little bit, but I just wanted to, again, to mention AB has 5 people and the CD group has 1. And so again, it could just be a funky result from one person. That can happen. That's why you never base a conclusion on an N of 1. So we'll see, but I think I have an explanation that I'll get to in a couple minutes. Now, the rectal stuff, nothing much changed. I mean, there may be a little bit, but this is even a decrease. But so these bars show variability. So this is kind of like one standard deviation. So this is the mean, and this is one standard deviation. So that would be what, like 56% of the response in the bell curve. So all of these are basically the same if you look at them. The red variability bars, they essentially say that these averages are the same. Now, if you look at this other individual, he's got much smaller variability. And so this one, I would say if you were looking at only this data, this is significantly higher than this one because those the variability lines don't overlap. Okay, once they don't overlap, it's like, okay, that distance is sufficient that you can say, yeah, these probably are different. Now, the thing that I want to point out most is kind of across the testing, there seems to be a general increase in the rectal pressure for this individual. Now, one thing we're not testing is we're not testing the fullness of the rectum during our experiment. So if the stimulation was actually causing material to move in, like promoting motility, that could explain these results. So we're actually promoting motility in that individual, so he's starting to fill and probably getting ready to do his bowel program. So that was something that was a bit unexpected. And if that proves to be true, that could be a really good effect of this stimulation that I know reduced motility is a big issue within the community. And so if there was a non-invasive stimulation-based method of improving that motility, I think that could be a big improvement in quality of life for individuals after injury. So stim didn't really seem to do much. So the yellow bars is interesting, but we really don't know what's going on. And again, just the numbers. So this wasn't as interesting to me as the sphincter results because it didn't really show anything, first off. And again, these are 2 different types of muscles. So the rectum is pure smooth muscle, and then the sphincter is mostly smooth, but with some skeletal muscle in there. So it could be that we are affecting only the skeletal muscle and not the smooth muscle. And these results here kind of support that conclusion, but we'll have to see. This also kind of supports that conclusion because this is the compliance curves. So again, pressure in the rectum and then the fill of the balloon. So this is increasing distension. This black line are standard values that we got from the literature in able-bodied individuals. So this is your comparison. Now, what we found is there are actually two kind of different presentations of compliance for individuals that came into the study. We had this high pressure, very low compliance presentation, and then we had a low pressure, good compliance presentation. And there's really nothing to predict who will have each of these. I believe this person, 10, was the C and D, and then the other people were A's and B's. And so it's not a severity thing that leads to whether you have good compliance or not. Perhaps it might be a level of injury, but we're not sure. We're collecting a bunch of different data points in terms of length from injury, or time since injury. And so if you think about it, perhaps somebody that was early on, maybe they have this phenotype, and as they progress further from their injury, it transitions to something like this or vice versa. So there are a bunch of different things going on, which is why we need more data. But again, this doesn't really seem to be doing much with stimulation aside from this one little bit, where the test stimulation or effective stimulation seem to increase that rectal pressure, but not in any of the other traces and not in any of the other participants. So it's not clear what's going on, but it doesn't really look like the stimulation is doing much for rectal activity. It's mainly a sphincter effect at this point. All right, so why are the bars going in different directions? This is the thing that I think is happening. So what I did was I took the data and I organized it based on which stimulation they got first. So they either got the sham stimulation first or they got the test stimulation first. When we designed the study, we made it so that half of them would get sham first and half would get test first for exactly this issue. If we had given them all the sham stimulation first, what you notice here is that the sham stimulation has an increase in anal pressure in the A and B group, but the test stimulation does not. So that tells me that the stimulation is doing something, but it doesn't really matter which one it is. Because if you give sham first, you have the bigger effect in the sham. And if you give the test stimulation first, you have the bigger effect in test stimulation. So it's not the difference between the stimulation types. It's not higher frequency, lower frequency is really how the body is determining what it does. It seems to be whichever one comes first, it will respond to. And then as it is essentially worked out throughout the experiment, it starts to fatigue. And so it's not able to produce these pressures anymore because the stimulation kind of tired out the muscle, is my interpretation. And so if we were to give the test stimulation first in every individual, we would say, oh, hey, this works perfectly. Excellent. They all responded to the test stimulation. They didn't respond to the sham stimulation. We win, write it up. We're going to get published. But the actual situation is a bit different. And my interpretation is that after injury, a lot of the systems below the injury go to a lower level of activity. Okay. There aren't as many descending things to promote activity, and you kind of get a lower level of activity overall in the spinal cord as well as kind of in the tissues resulting from that. So I think what we did is when we gave them the stimulation, we kind of kicked the system in the butt and got it moving. Okay, it didn't matter which one it was, but as soon as we gave them something to promote activity in that system, it became more active. But because it hasn't been active very much, it's like me when I go from my couch and try and work out. I get tired very quickly. I can do it for a couple minutes and then I'm done. So essentially, that's what I think is happening. Now, long term, that probably wouldn't be great. So if you're going for continence and now you're fatiguing the system with your treatment, that's going to lead to more incontinence. The nice thing is that this system is actually fatigue resistant after a while. So one thing in other stimulation paradigms that um, we've written up and submitted for grants, and the reviewers have come back and said, well, what about fatigue resistance? Like, yeah, but this will help them empty. And they're like, yeah, but it won't work forever because they'll get fatigue resistance and then it won't work anymore. In this situation, I think it might actually be a benefit because you're actually training the muscle to work harder. And so it may actually increase that resting pressure without stimulation by promoting activity in that system at baseline, almost like a rehabilitation rather than just, I push a button and now I'm continent. It's actually training your body to become continent again, which I think would be a benefit long term. So we don't know how this is going to work out. I'm hoping that's how it works. We will see after we have more data to look at it. We also have an aim to a home trial that we're testing where the participants will use the stimulation system for between 6 and 8 hours a day. So if it is increasing continence by increasing that sphincter activity, we want it on during the day so that there are no episodes. And then once they turn it off, then they can do their bowel program or go about whatever they're doing. We feel that this may help promote engagement with the community as well as employment if you don't have to worry about having accidents. But it really remains to be seen if that stimulation is even feasible for a person to do during their day-to-day, or if it will be effective. I think this is kind of the first test of whether or not that's going to work. Are we inducing fatigue? And if we are inducing fatigue, does that actually become resistant to the stimulation and kind of promote that continence long term, which is what we're hoping for. Sorry, I've got two screens and now I can't see it. So the order presentation didn't really do anything in the rectal data, just like everything else. It seems like smooth muscle, or at least the rectal smooth muscle is controlled differently than the sphincter smooth muscle because we're able to get effects in one but not the other. All right. So overall, we seem to be increasing sphincter pressure, which is what we want. Increase in sphincter pressure means more continence. We don't really seem to be doing much with the rectal compliance, so what the relaxation of that organ. I'm not sure if that's going to come out of this study. It would be interesting, but it doesn't look like that's happening. And then this order of effect with the sham stimulation being effective is really strange, honestly. It was unexpected. We chose the sham stimulation because it's not supposed to do anything. They're supposed to be able to feel it, but it's not supposed to actually do anything. And it looks like it's actually doing something. So it's a much lower frequency. It's 2 hertz versus 20 hertz. And so it could actually be, if that's effective for a person, it can make their battery last longer because there's not as much energy use. But it could also open the door to other interpretations of, okay, what if we just provide kind of local stimulation? Will that help the systems work better? And so kind of recover from these complications in a way that is more effective long term. And then that fatigue question is really a big one. What are we actually doing? And if that's what we're doing, is that going to impair continence long term, or is it going to improve it? And so those are really the big questions that we're trying to answer with these data. And so now it's time for you guys to tell me what you think. I did want to say thank you to the study team participants. You guys have been great for your feedback, and the grant agency for funding us to do the work. If you or anybody you know wants to participate, the contact information is here. You can write Ashley an email. She's amazing. She'll get you a scheduled day as soon as she can, or just email me directly, and I can do that as well. So anything. Now's your time to tell me this is stupid or it's great or whatever it is you want to say. If you think that you would participate, or if you think that you could fit this into your life, anything goes. Go ahead.
I have a question.
Sure.
At the initial points where you are beginning the treatment with the balloon or anything such as that,
Hmm.
Does that stimulate other areas of the body? For instance, sweating, for instance, autonomic dysreflexia, things such as that.
That's a great question. So one
And,
of the
and the
big,
blood and the blood pressures as well.
so we track blood pressure every 5 minutes throughout the study. Autonomic dysreflexia is something we are highly aware of and want to make sure. One of the top three causes of AD is bowel distension, bladder distension, and skin ulcers. And so we try to look out for the two that we're looking at. So any skin ulcers or or that distension. So we monitor blood pressure. It's happened in one person so far has had kind of mild AD. So as their blood pressure started to go up, we took a break and it started to come back down. And so we were able to manage it that way. It's expected that it might happen. And we do have uh, the clinical staff there in case it does. But it is something we're looking out for sure.
Very, very good.
Um, it's not the most comfortable of studies to be in because of the rectal catheter, right? And I find that a lot of people in discussing bowel health, it can be a weird taboo topic. I mean, I don't mind. I was raised by a nurse, so we talked about this stuff at the table when we were having dinner, but it can be an uncomfortable process, I think. And so we do our best to try and make the participant feel comfortable. We do a lot of laughing, joking, having music on, stuff like that, just to try and make it the least comfortable or the least uncomfortable possible, so that when they come in, they don't feel like, okay, what are you going to stick in me today? We want to make sure that they feel like they're part of the process as well. Basically, just on maybe these incontinence questions, don't give more personal information than you feel you need to, but I've had a lot of people saying, well, what about motility? I don't really have accidents. I tend to have constipation. So what do we have for that? Is that kind of where you guys fall? Which one would be more of a concern for you?
Geez, why is nobody jumping in here?
We're waiting for you, Tim.
It was so exciting. Everybody's just thinking.
I don't have problems, bowels typically. So, but the study is, the whole idea and the contraption. I mean, it seems like an amazing option if it works for people.
Yeah. If it works, right? That's always the question.
Yeah.
Do you know many people that do have issues in this area?
I mean, there's one person I could speak with about it, but not as many that you would think. That we don't talk about that as much.
Mm,
Usually more bladder stuff. But
right.
no, I honestly don't know as many people that have incontinence issues
Okay.
or constipation. I know people that do have constipation, a little bit of constipation issues, but sorry. How would that help for constipation issues?
We don't really know yet.
Okay.
I'm hoping that it will help. It seemed to help. It might have been so. Whenever somebody comes in, we ask them to do their bowel program that morning, so that we can kind of make sure they're not going to have an accident when they're with us, and also that it's empty because we have to put a balloon in there. But it looked like that one person did have like loading, and so that tells me that we might actually be promoting motility, hopefully. If we can, that would be great.
Okay. Don't worry.
Sorry about that.
It's
It's a
not
weird
gonna happen.
tickle in my throat I can't get rid of. Yeah, so it would be great if it did promote motility, because there isn't much that does that.
Rob, it's the old question, or it's the same question that many people have and maybe not even discuss, is that have I just had my bowel program or my episode of going to the bathroom, and nothing scheduled, but have I gone complete? And you know, those spinal cord injuries tend to rear their ugly heads later on when you least expect it. And so that you want that bowel program and or that episode of what we're doing to eliminate as much as we can.
Right. Yeah, I know that Dennis is working on something that's kind of like it's an electrical stimulation unit that you insert prior to your bowel program. Basically replaces DigStim. So it helps move everything down using stimulation. And so that can help with more efficient emptying. And I think he did see that it was starting to help people reduce the time it takes to complete a bowel program, which is a benefit, right? Especially if it's over an hour. If you can get it down to 20 minutes, I mean, that's a huge amount of time. So there are things, there aren't very many non-surgical options that can help with that. So if this was able to, that I think that would be a benefit for probably a larger number of people than having continence issues. But because of how difficult those episodes can be to experience, we thought we would focus on that first, especially since the stimulation kind of does that in the bladder system. We thought it might do that in the bowel system as well. And the questionnaires that we've been asking participants to complete talk about not just the issues that they're having, but how that affects their life, right? So questions like, do you worry about having an accident? You may only have one once every 6 months, but every time you leave the house, you worry that it's going to be today, sort of thing. And so, even though incontinence may be infrequent, it's kind of this big, almost trauma event when it does happen, because if it happens out in public, it's very embarrassing. It's difficult to clean up, and you've just got all these things against you. And so we thought we would focus on this first, but we do want to promote motility as well, because I think that would definitely help. And it's along the entire GI, especially if you have a higher injury. You've got gastroparesis, you've got issues in the small intestine, large intestine, kind of the whole run. And so if you could promote that activity throughout, you might promote healthier bowel function just because it's moving its way out, right? Keep the train moving.
That DigStim contract it idea or whatever you're saying, that could increase or decrease, I'm sorry, the time. Individuals that do, that way, which I am one, and I know more people that do as well. So
yeah, currently the study is being run through the VA. So that's not open to non-veterans yet. But I kind of have a list of people that have said, oh, hey, if you got something for motility, let me know. So we're hoping that once that's conducted, we can actually open it up to non-veterans and see how it works for them. It's probably to share too much personal information, but I've had issues with constipation throughout my life, and it is very uncomfortable. And so I imagine that, just the, fairly few bouts that I've had of it over the years, I remember. And so having to deal with that kind of consistently and constantly, I imagine would be very difficult. And so we are trying to promote those as well. Motility stuff, that it's not just, okay, I take a laxative. It could be something that is more effective than that, and probably a lot more comfortable than that as well. Hopefully. As comfortable as sticking an electrical probe in there can be.
In the rectal cavity, as they say.
Yes. Yes. Well, you know, to each their own, right? So let me ask you this. If you had to wear a surface stimulation unit for 6 hours a day, is that something you feel you'd be able to do and incorporate into your life and not have it be kind of this huge thing that's all you're doing?
Personally, myself,
Sure.
uh,
Whatever.
I I think right now with how I am with my situation, I don't think I would need it. But
Hmm.
maybe if as things progress as I get older and I have more issues, then obviously, yeah, if it was something that helped for sure, especially like you were saying, there's instances where I'm sure a lot of people have anxiety after they've done their bowel treatment. As Don was saying, you go out and you're still, are you done? That sort of question in your back of your mind. But yeah,
Yeah, I mean, even as like you were saying, a safety blanket almost. Like I've got backup, and that might help people feel more comfortable as well.
yeah, for sure.
Yeah, I agree. I mean, any other comments or um, I'm available.
Any other comments for right now?
Okay, well, if something comes to you later, feel free to email me. Um, I'm not in my office super often, so calling that number probably wouldn't work too well, but definitely shoot me an email, even if it's, oh, hey, I thought of this after I got off the call. No problem. I'd be happy to answer it. Um, if you want to participate or you know somebody who does, that's fine too. I'm not here to, kind of beat the drum and get everybody out there, but I do want to let you know what we're doing. We are pretty excited about it. We think it's going in a direction that would be helpful. If you want to come in, that's great. There's a small stipend that you get for completing the study. So that's always nice. And we do provide transportation as well if you need it. So if any of that helps either you or somebody that you know, kind of, uh, if that helps them participate if they want to, great. Let me know. Otherwise, I will be here doing my thing, and I'll be happy to come back and speak whenever you guys would like.
Great. Thanks.
So thanks again for having me.
Yeah, thank you so much for being here. And I will include Dr.
Rob.
Hulley's email address in the replay email when it comes out this week. So if you do have feedback, if you think of anything between now and then, don't hesitate to reach out and share your thoughts. So thank you again for everybody coming. Let me go ahead and stop recording.